So when we discuss that cancer is a disease that is eminently genetic, that it needs some mutations to happen, what happened is that for uveal melanoma, we do know after several mounting evidence, we do know the main mutations that drives the cancer, the uveal melanoma cancer to grow, like GNAQ, GNA11, cis-LTR2. So those mutations are the drivers. They are exclusive. So always when you have one type of mutation like GNAQ, you don't have like PLCB4. So these drivers they dictate the uveal melanoma growth. And something very important for uveal melanoma and very particular of ocular eye for this disease is that different from cutaneous melanoma, where we are always concerned about lymph nodes, or when you might hear like sentinel lymph nodes. For uveal melanoma, this is particular. It doesn't go to lymph nodes. The disease goes to the bloodstream. So it affects the bloodstream. And that is what we call hematogenous dissemination. And this happens with up to half of the patients once after having the primary tumor treated. And what I want to show here is that half of those patients, meaning 50% of uveal melanoma patients following curative intent treatment of the local primary tumor in the eye, they will develop a recurrence. And it's very important to understand that the primary organ that is established for uveal melanoma in the vast majority of the cases is that will aim for the liver. There is a hepatotropism, very important for uveal melanoma cells, that it goes to the liver. So that's one of the reasons that once patients are on follow-up, we are always worried with the liver imaging. We can do an MRI, we can do an ultrasound, and as I said, this varies across practice, but it needs to have some sort of imaging of the liver. So once we know that up to 50% of patients will develop a recurrence, and most of the times in the liver, the way we treat these patients is that once the patients have this disease elsewhere from the eye, these patients we know that the cells are in the bloodstream. We know that these patients need some sort of systemic treatment. But the problem is that until 2021, when trials were developing for investigating novel technologies, novel molecules to treat these patients, what we know is that no systemic treatment, and meaning chemotherapy or the classic immunotherapy, what we call checkpoint inhibitors, they have not provided patients with a very good response rate, and ultimately no improvement in overall survival. So when you see here extensive literature data showing that the median overall survival once patient is diagnosed with advanced metastatic melanoma, the median overall survival was ranging up to 12 months. And this is very important because until here, we did not have any standard of care treatment to offer patients that were able to improve overall survival. However, what is important, even here, when we think about median overall survival spanning from until 2019, 2020, what we know is that this disease is heterogeneous. So we do have a subset of patients that will have a very prolonged overall survival compared to this 12 months, which is just a statistical analysis. This is the median, but this disease is indeed quite heterogeneous, as you will see.